So as a pain physician, I'd say my skills are probably stronger in managing some of the pain components of each of these syndromes. And, I've sort of by default had to learn, for example, how to start to manage some of the POTS related symptoms, even though it's not specific to a pain medicine, if you will. But, as you had sort of mentioned in your lecture, that failure to address that can sometimes lead to inability to proceed with management of the other syndromes. So my question to you around your driving the bus analogy, how do you as a clinician sort of decide which condition you feel is driving the bus and where you even need to start? Because that's something that I think a lot of providers would struggle with when they're trying to figure out where do I even begin? Like, which problem do I start with first? Do you go with what is the most distressing symptom to the patient, or do you go with what you think the biggest syndromic problem is?
Yeah, so that is really the art of medicine in these patients. It's why they're so complicated because there's no right answer for any particular person. But I definitely start by looking at whether or not there's post-exertional malaise, whether or not there's orthostatic intolerance. I'm always doing Nasoline tests. I may do a diagnostic trial of IV fluids even in those cases. I look for mast cell and I look at sympathetic overdrive first. And I try to think of those as upstream of causing many downstream additional symptoms. And so I look at the symptoms that are most distressing to them and say, okay, what is upstream that may be driving those most? But I think you're never going to go wrong identifying post-exertional malaise or treating orthostatic intolerance first, especially when there. And so going back to that idea of a IV fluid diagnostic trial, it's amazing how much you can learn from that. As long as they don't have increased intracranial hypertension, you'll find out how much of their pain can improve, how much of their fatigue can improve, how much of their nausea can improve. And it gives you a sense of whether you should keep pursuing sort of pharmacological or other behavioral interventions for orthostatic intolerance, or if that doesn't improve much, maybe we need to start thinking about one of these other categories first. So there's no easy right answer by any means, but I do try to think about what is as far upstream as possible that could have the greatest impact on multiple systems across multiple different organs.
I have a number of patients who have problems with B12 and iron. They're on infusions. I have one family where they take daily subcutaneous B12 and have felt better. So a blood level of B12 or iron may not necessarily represent what's in the cell. And I'm just wondering, in your research, is there anything going on in the intracellular level in the energy production that you're talking about, or reduced with mitochondria, ribose, a whole bunch of things? Is there an explanation why iron infusions may be helping these patients and why B12 may be helping these patients?
Yeah, so as far as B12 is concerned, there's some really good research being done in the ME/CFS field, specifically looking at the metabolic function or dysfunction that occurs in that syndrome. That's sort of implicating B12 in some of the metabolic pathways that are disturbed. I think we have a lot more to learn about that, but there's always been sort of a traditional clinical teaching in ME/CFS specifically that supplementing B12 helps people feel better 9 times out of 10, even when the levels are considered high on serum testing. So we certainly have no reason not to aggressively treat with B12. As far as iron infusions, I haven't totally seen that people feel better with iron infusions unless they are iron deficient anemic. And that often occurs with things like endometriosis or some of the other gynecological issues that we might see in EDS. But I haven't seen that to be universally true of our patients.
There seems to be an absorption problem in the gut. And I think all these things with connective tissue, blood flow, venous congestion in the gut, I think some of these things are impairing the absorption of these nutrients. And that's where they're not getting, and they may just not be flowing, right? Because as you say, and I have several patients where the IV fluid has been very beneficial. We do have some with lines put in because it was the thing that allowed them to get back. They get 2 days of recharge, and then it sort of drifts, and then they get another infusion. And it's sort of a hard thing to deal with on an ongoing basis. But I do like your idea that it may be a helpful test. And then for some families or some individuals, it may be actually a useful therapy.
And I think you make a really good point too with the absorption. There are people who have significant mast cell activation will have reduced absorption of iron, of B12, and even of other oral medications that you give them. So you may find that when you treat mast cell activation better, all of a sudden their POTS meds work better.
There was a question from the audience about your ketotifen, using it as a compounded form versus, say, a prepared form. I know you kind of explained there may be other ingredients that may make the ketotifen non-effective. Is that the reason you're mentioning compounded versus, say, a standard pill?
So I'm not aware of any commercially available ketotifen other than eye drops. So it's almost always been available only as a compounded formulation, at least in the United States. Certainly.
I prescribed it the other day. It's available in Canada.
Yeah, so in Canada, it's available as Zaditen in 1 milligram tablets. So that might answer that participant's question. But I think even in Canada, there's there's value in prescribing it as a compounded version. Number one, either because of the excipients, but also the expense. So the tablets actually end up costing the patients who are on doses of 4 milligrams twice daily close to $300 a month, which isn't sustainable or sometimes isn't covered. Whereas we can get it compounded. There's certain pharmacies in the Toronto area that will compound it for like $70 a month, which is a much more affordable option for patients who may not have the coverage. So that kind of might be, an interesting point on a couple reasons for compounding ketotifen. There's also a question in the chat about the concern around that many medications are required for long-term maintenance of these comorbid conditions and that can stress the liver. Is there any recommendations around, at what point you become concerned about the possibility of elevated liver enzymes and what is your sort of rules or indications to adjust the medication or even stopping them?
Yeah, so certainly managing a multi-system illness like this requires more polypharmacy than I think any of us would really choose to do otherwise. That being said, I have not found that use of a lot of the drugs that were included in this particular presentation today to lead to transaminitis of any kind. When I do see elevated liver enzymes, it's generally mild, and it's almost always due to non-alcoholic fatty liver disease, which we actually see at a slightly higher rate, at least in ME/CFS specifically. And we think that that is related to some of the metabolic deficiencies that define that illness. But I haven't really come across issues with drug intolerance from a hepatotoxicity perspective.
Dr. Yellman, again, if I could ask you, hopefully you can still hear me. In Utah, do you have an EDS? Program? Do you have centers? And there was a question: who should own EDS among the specialties?
Well, as far as EDS centers, I know that at the University of Utah down the road from us, genetics often will help make the diagnosis of EDS. But of course, in our hypermobile spectrum disorders and hEDS, they're not quite as helpful since it's not a single gene that's involved there. There's a lot of physical therapy interest in hEDS as well, but I don't think there's a kind of comprehensive internal medicine-based EDS center beyond what we offer, sort of treating ME/CFS and its related comorbid conditions at the Bateman-Horne Center. As far as what specialty should help there, I think that's a really difficult question, and I think it's more likely that we need multi-specialty centers. We need assistance from physical therapy and occupational therapy and pelvic floor physical therapy. We need good internal medicine. We need good pain medicine and good neurology, for example. Neurosurgery, as we kind of talked about at the end of my lecture, should, if there were more neurosurgeons who were interested in these conditions to begin with, who understood them to begin with, I'd love to have them be colleagues that we could call on. But that's, like we said, it's evolving and we're not quite there yet.
It might be interesting to look at other countries, see if anyone in the world has a better program or has brought it together, because I do know that is one of the main issues with our patients is where to go to, who's going to know what to know, and how to integrate these various sources. And I know Dr. Norris in MUSC is planning to hopefully get this kind of a one-stop place where people can kind of be understood, validated, and the different areas be linked. Dr. Patel, who's a surgeon there, has seen one of my patients recently, and he was all over mast cell therapy. And I found it very encouraging that a neurosurgeon would be into mast cell therapy. And I found that very encouraging that his knowledge was improving, as all of us are.
The surgical outcomes are a lot better when you have good mast cell control going into a surgery, and they have a lot more complications when it is uncontrolled coming out. But at the end of the day, I think it's just important to remind everybody that at some level, we all need to take it upon ourselves to validate these patients, help them out. You don't have to be perfect. You don't have to have all the answers. You don't have to be able to manage all of these conditions we just covered. Be aware of them, validate them, do the best you can, and you're going to be doing better for that patient than they've probably had anywhere else in the medical system.
100%. There is a couple questions in the chat. One participant is asking, once diagnosed with IJV compression, internal jugular vein compression, what would the next step look like for symptom relief with our current understanding of that problem?
Yeah, so the jugular venous compression syndromes are really an evolving area of knowledge, and quite difficult to make a diagnosis for. I generally, when I suspect that could be the case, I will often give people a diagnostic trial of acetazolamide, which is a diuretic that essentially opens up the arachnoid granulations and the connection between the venous system and the CSF, and ultimately helps reduce some of that intracerebral pressure. Topiramate is another option that you have, but dopamax, a lot of cognitive side effects there. They're actually saying that the GLP-1 agonists may also reduce intracerebral pressure. So if you have someone that's a good candidate for that, otherwise that might be a consideration there. But I usually will start with the diagnostic trial of acetazolamide. Whether or not they tolerate it well from a nausea, vomiting perspective or other perspective, just giving it as a diagnostic trial to see if it reduces significant headaches, pressure behind the eyes, brain fog, increasing tinnitus in the ears can be really helpful as a diagnostic tool to say whether or not this is even contributing to someone's pathology. Where it gets really tough is when you've made that diagnosis, what do you do next, right? Do you just go and you have to fix the internal jugular compression itself? What kind of imaging do you get? What surgeon do you send them to? Is it a neurosurgeon? Is it an ear, nose, and throat that helps dissect the area open? Those are difficult questions, but you also have to consider what else is going on in that area, right? Do they have craniocervical instability? Do they have active mast cell that you haven't controlled in that area that is progressing or contributing to a kind of a transient internal jugular venous compression? I've seen good mast cell therapy actually reduce symptoms in that regard. Do they have tethered cord, right? When all of these things are working together, it's hard to figure out what do you prioritize first. So I had one patient, for example, who had severe intracranial hypertension. I got her on high doses of acetazolamide, not just from a diagnostic perspective, but from a maintenance perspective. And it completely resolved her headaches, but it got us into a pickle because I think as we reduce the intracerebral pressure, we reduce this sort of outward force that almost stabilized the brainstem in the context of CCI. And as soon as we reduced that volume, there was more motion at the brainstem and her dysautonomia symptoms got worse. And so in some ways I was doing the right thing. And in other ways I precipitated something that was always there that we needed to identify and ultimately treat anyway, but made things worse in the short term. So these conditions are dynamic and they're all interplaying with each other. So having that specialized center where we can evaluate all these things together and involve neurosurgical teams, et cetera, would be on my wish list for sure.
You'd commented on lower doses of benzodiazepines potentially being helpful, and this participant is asking what dosage specifically do you find is helpful in your MCAS patients?
Yeah, so benzodiazepines are mast cell stabilizers, but I particularly think about them when people have a lot of those sympathetic overdrive type symptoms, or when they have a lot of medication insensitivities. I have people, when I first started in this field, it was amazing to me when people would come in and say, you know, I took a Tylenol and I didn't sleep for 3 days. And doctors tell me I'm crazy, like that can't happen. And of course, that's not the pharmacological action of the drug, but that is this person's neurological system reacting to something that it's detecting as a threat, right? And so when you have multiple insensitivities that are not just allergic or histamine based across multiple different drug classes, benzodiazepines can really be helpful in that case as well. So really from a calming the sympathetic nervous system perspective is where I start when I look at those, and especially if they don't have room for alpha blockers or beta blockers, they don't have access to things like a stellate ganglion block. Maybe they don't have enough ability to concentrate and focus on things like exercises that calm down their nervous system themselves, like those brain retraining programs, which are really all about calming down, consciously calming your sympathetic nervous system, then I will reach for benzodiazepines. And I try to do the lowest possible dose, and it really varies across patient to patient. So start low, go slow, but ultimately help them control their symptoms. And you would think, okay, someone's brain fog, they're tired, I'm just going to make that worse if I add benzodiazepines. But you'd be surprised at how much people actually clear up and have more energy when you take away the siphon of that energy, which is this sympathetic overdrive.